I have the honor of introducing her honor, Judge Kelly McKibben. Judge McKibben is a dependency circuit judge in Brevard County, Circuit 18. I have known Judge McKibben for many years, long before she became a judge. She has a lot of experience, a lot of history in the dependency system. So we are fortunate to have a jurist who understands pretty much what we deal with day in and day out. And so Judge McKibben will be introducing the team that she has with her today. And so with that, I'll pass it on to Judge McKibben.
Thank you, Mr. Melvin. Good afternoon, everyone.
Good afternoon.
I'm assuming with the microphone that you can all hear me okay.
Yeah.
All right, and I'm used to yelling in court anyway, right? All right, well, we are very pleased to be here this afternoon. The topic that we're going to be talking about for the next 50 minutes or so is in regards to drug court and substance abuse issues. And my team members that I have with me here today, they will certainly be introducing themselves and giving you their brief professional background, but just very briefly, I'd like to introduce Regina Wassam, Stephanie Johnson, and Elizabeth Maxwell. She is our substance abuse expert, and I think that you're going to find her portion of the presentation very interesting on the latest trends of drug use and those types of issues, and our substance abusers and the frequency and the types of drugs of choice. So with that, just to give you a very brief overview of my background, as mentioned, I was an attorney for the Department of Children and Families right out of law school. Then I was appointed as a county judge. I served for almost 9 years. And then in 2013, was appointed to the circuit bench and have now been presiding in the dependency division for a number of years. So kind of full circle as to what I started my career doing. But we are going to be talking about substance abuse, and to let you know, I do preside currently over the dependency division in Brevard County, the 18th Judicial Circuit, and I also preside over the adult felony drug court. So those are the adult offenders that are either already in the criminal justice system or trying to, through a diversionary program, divert their criminal charges by participating in drug court. And I also preside over our family drug court program. And that is something that we handle within our dependency division. And I also handle the related domestic relations cases. You all have handouts, and there's a lot of statistics that I've included for your information. I'm certainly not going to go over all of those statistics, but I did want to start with a brief video to talk about substance abuse and why it's such an important issue. Some of you may have seen this video. Very shocking. For those that you haven't not seen it, just be forewarned, it is a bit shocking.
The images are horrifying and heartbreaking. A couple unconscious from a suspected drug overdose while the woman's 4-year-old grandson sits helpless in the back seat. Officers in East Liverpool, Ohio want the photos to be a wake-up call.
When you see that, the shock factor, you get that lump in your throat. It's sad, especially when you have children of your own.
Police say the couple's car narrowly missed a group of children getting off a school bus before screeching to a stop. James Acord and Rhonda Pasek have been arrested. The child taken to protective custody.
When you see something like that, I think you put a face to it, it's just an addiction. It's just terrible.
All across Ohio, heroin overdoses are spiking. Over the past 2 days in Cincinnati alone, 76 overdoses. Every month, 92 on average, double the rate from last year. Nan Franks has been an addiction specialist here for 40 years.
Why Ohio?
Well, we think in Ohio because we have a long history with the opiate crisis. The kind of pill mill industry was very big in southeastern Ohio.
Addicts are increasingly ending up on Dr. Lakshmi Samarko's autopsy table. Heroin now being laced with deadly synthetics.
It's very concerning that people are pushing the envelope, to the next high, the biggest high, the maximum high.
And as these photos show, children are living through the horror of addiction, too. Tonight, there are calls for Ohio's governor to declare a public health emergency and quadruple the number of treatment options. Right now, those seeking help are often put on wait lists. Lester?
Blake McCoy. Thank you, Blake.
So you're thinking, okay, well that's Ohio. Well, we're here in Florida, and I have other headlines to talk about. Manatee County, Florida's morgue running out of space due to heroin overdose deaths. As reported in the Bradenton Herald, there were 110 autopsies from heroin and fentanyl overdoses. 62 of them came from Manatee County, right here in the state of Florida. Manatee County Sheriff's Office had to respond to 733 suspected overdoses in a period of 8 months between January and August. So this is not just out of state, not our issue, we're here in Florida. This is a major issue, substance abuse. And I'm going to talk briefly about drug courts because drug court and the model for drug court is effective. Drug courts work. In fact, 75% of the adult criminal drug court graduates never are seen in another set of handcuffs. In other words, they are criminal free from that point on once they've graduated from drug court. And in fact, drug courts have been in existence for over 20 years now. Drug court, the theory behind drug court is therapeutic jurisprudence. What does that mean? That means judicial oversight of a defendant or a parent, because we all deal with, obviously, parents that have substance abuse issues, on a very frequent, intense basis with intense services by the substance abuse providers, whether that be inpatient treatment or aftercare treatment, but it is intense oversight and immediate rewards and sanctions for the parents. So if they test positive for a substance, then they face a sanction. If they don't meet their counseling requirements, they face a sanction. If they are compliant, they can be rewarded for that and have less frequent court events. But drug courts are shown to be effective, and just some of the statistics I want to highlight. For example, approximately 95% of those that go through drug court, those that do not go through drug court will return to drug abuse after release from prison. That's a pretty startling statistic. Accountability in drug court is the key. And 60 to 80% of addicted offenders drop out of treatment prematurely. But when you have judicial oversight, meaning you have court hearings approximately every 2 weeks to hold them accountable, to tell them they're doing a good job, to tell them that they need to focus and make drug court and their priorities and focus on their priorities of becoming substance free. Drug courts do reduce crime. In fact, statistics show that drug courts significantly reduce crime as much as 45% more than any other sentencing options versus imprisonment, versus any other type of punishment, probation, things of that nature. Drug courts and the intense oversight have shown to be very effective in reducing crime. They also save money. The next slide indicates various statistics on the money that's saved, and I just want to highlight that there have been cost savings ranging from $3,000 to $13,000 per client. That's a huge, significant savings. And it also results in less prison time, less arrests, and reduced victimization. Drug courts also ensure compliance, and in fact, drug courts are 6 times more likely to keep offenders in treatment long enough for them to actually become substance free. Now, of course, we do have relapses, and I'm sure that Ms. Maxwell is going to cover that and talk more about that because she is the expert, but we do see folks. In fact, I had drug court this morning. I had to revoke 3 of our adult offenders from the program because they consistently failed to test. I have no way to know if they're substance-free or not, and they did not meet their meeting requirements, and 3 right in a row on my docket this morning, we revoked from the program. So they go back to the trial court, face a violation, and then therefore more potential imprisonment. But as far as meth addictions, that's also a big issue. We talked about heroin, you saw the video about the heroin, it's quite shocking. But meth addiction, drug courts help reduce methamphetamine use by more than 50% compared to outpatient treatment alone. And let's talk about families, because that's obviously why you all are involved. As guardians ad litem, parents in family drug court are twice as likely to go to treatment and complete it. Again, it's that intense oversight. The judge is holding them accountable, the treatment team is holding them accountable, and when they slip up, we try to give them the resources and assistance that they need. But family reunification rates are 50% higher for those that are involved in the family drug court. In addition, as you all know, most of our cases involve either substance abuse or domestic violence. So to try to work on those substance abuse issues, in the 60 to 80% of our cases that involve those substance abuse issues, family drug court has been deemed to be effective. And in fact, more than 60% of parents in dependency cases do not comply adequately with their substance abuse treatment conditions when you compare them to those that have actually gone through the programs. I've included all the sources of these statistics, and like I said, I'll let you all look at those later, but I'm just here to say that drug court does work. Now, I know that every single circuit and county doesn't have a family drug court established. We're working hard in Brevard County to try to get those parents identified that would be good candidates for our program. We do follow a team approach, and Ms. Wasson's going to briefly talk about that as well, but the big statistic that I want to highlight on this slide is that 91% of the family drug court participants did not have their parental rights terminated when compared to those that did go through the regular case plan process. So again, the intense oversight is very effective. There are currently 118 drug court programs in the state of Florida, 54 adults, 26 juvenile, 18 family dependency treatment courts, and so there are various drug courts throughout the entire state. There's a few that also have a veteran treatment court, focusing on the veterans, and then some designated DWI or driving under the influence courts as well. So at this time, I'd like to turn it over to our team members because, again, they're going to be talking more about the actual substance abuse issues. And at this time, Ms. Regina Wasson, she is our dependency court liaison. She will tell you about her professional background and what her role is in our drug court team. Ms. Wasson?
Good afternoon, everyone. As she said, I'm Regina Wasson, and I'm the Family Drug Court Coordinator. A little bit about my background. I've worked in child welfare. This year will be 24 years. I've worked in various positions. I started out as a child protective investigator with DCF. I was a paralegal with COS for many years, and for the past 8 years, I have worked as the court liaison in the dependency courtroom with Brevard Family Partnership, which is the lead agency in Brevard County. As the coordinator, I receive referrals from any source of within the dependency system. I receive referrals from case managers, DCF, parents, attorneys, in fact. Once I receive the referral, the drug court team staffs the case to make sure that it's appropriate. And I can pretty much tell you if the parent has a history of substance abuse and they have a strong will to be substance-free, we accept them into the program. I'll tell you a little bit about the drug court team in Brevard. It's made up of, we have a DCF attorney on board, we have a guardian ad litem attorney that's part of the team, GAL coordinators are on there, a treatment provider is present, and the case manager assigned to the case is part of the team as well as the clinical liaison. We, as Judge McKibben said, we hold drug court generally about every 2 weeks, and the drug court team meets, we meet like an hour before court to discuss the cases and to come up with recommendations for the court. I facilitate the staffing by keeping the team on task, being mindful of that 1 hour we only have, and making sure we can get through all the cases so we're prepared for court at the 10 o'clock hour. I prepare the docket for the drug court team and the other parties. And the drug court docket, when I prepare it, what information I include is the client information, the children's names, date of birth, last drug screen results, upcoming court dates, notes from the team staffing, and our recommendations to the court. Some additional duties I do. I distribute the drug program court pamphlets to parents at shelters who have substance abuse history. And if they seem to be interested, I inquire, I advise them they should speak to their attorney to see if their attorney would be on board for them entering into the program. I prepare the participation contract that they sign at the initial hearing, and I also provide them with the family drug court handbook. In addition to that, at that initial hearing, once they sign the paperwork and everyone's on board, I do provide orientation to the clients after court, which basically I just go over what the requirements and expectations of the program are. And mainly I just highlight to the parents, you need to be honest with the team. If you run into problems, let us know. We'll try to help you. And go over the 4 phases that are involved. Go over examples of sanctions and incentives that may happen for them. I also maintain data for the Office of OSCA, the Office of State Courts Administration. They ask that I keep up with the number of referrals we have, how many children enter, reunification stats, those kind of things. I report on that a couple of times a year to that office. Lastly, I'm also known as the P lady. I do conduct urine screens right in the courtroom. Well, not in the courtroom, in the bathroom. I do sometimes in the holding cell. I have 2 different kind of cups I use. One is a 12 panel, which obviously tests for 12 different substances. I have a temperature gauge on it that will let me know if it's been altered, and I have 3 other control panels on it that ensures that this is a valid sample. And that 12 panel, it will test up to 48 hours. If they've used within 48 hours, it will be come up positive. Except for the THC. THC, as y'all know, stays in 30 days or more. I also have another test that is a test for alcohol. It's a 9-panel test for alcohol and 8 other substances. And if a client has used alcohol within 70 hours, it will test positive. A couple of examples of tampering with the test I'll share with y'all. I had one gal in the holding cell I was testing, and I'm not quite sure why she decided to wear a very thin, very tight-fitting dress, and I noticed she had a little bump right here. And I said, "What is that?" And she acted all nervous, and I'm like, "What? Something's going on. What are you doing?" And she pulls up her dress, and she had taped a pill bottle of pee to her stomach right here. And I'm not quite sure why she decided, because I probably would have noticed if she had worn a moo or something like that. But her dress was so tight. I don't understand that. Another example was a male.
Wait, let's hear what happened. You heard a pop, right?
Yeah. Well, that was another example.
Okay.
This lady had a pill bottle in
another place.
Another place. I do observe the females. Obviously, I can't observe the males testing. And one day I was standing outside the male's bathroom waiting on the client to come out. And this attorney walks out and says, "I don't know what's going on in there, but this man in there is asking people for, I need a clean pee. Can you pee for me? Can you pee for me?" So I say to those clients, why don't you work as hard getting your children back as you do, trying to, mess up this drug test. So yeah, it's never a dull moment. They're always trying to fool you somehow. So I will turn it over to my next team member, Stephanie Jackson.
Certainly don't have anything that good. Okay, good afternoon. My name is Stephanie Johnson. I am with, our CBC in Brevard County is called Brevard Family Partnership, and my role there is the intake and placement supervisor. as a dual hat, I'm also the clinical liaison with the Family Drug Court team. My background goes into not 24 years, but 23 years ago, I joined the Department of Children and Families and spent 7 years as a case manager and as a consultant with the Department of Children and Families before I moved on to the Agency for Persons with Disabilities, where I learned a whole lot about developmental disabilities. I was on the Med Waiver program. So I did that for 7 years, and then I went into mental health and substance abuse. So the last 7 years, I focused on mental health, became a licensed clinician, and came full circle back to child welfare. So I kind of have come back to where I started 23 years ago. Found my way back to Kelly and Regina, whom I knew back then as well. It was kind of funny. So my role on the treatment team, when we meet every 2 weeks. We all come to the courthouse, and I certainly want to offer some clinical insight on the participants who have applied and who we're considering to bring on to be in drug court. I also want to help them understand how mental health may affect their treatment process because of whatever mental health disorders they may have existing when they come in, which we see over and over. There's a great number of those that do have both struggle areas. What I do in the understanding of what we call a co-occurring disorder, has anybody heard of that?
Some people shaking their heads, but
So a co-occurring disorder is the existence of both a mental health and a substance abuse. That's referred to as a co-occurring disorder. So when someone comes in and they have what you believe to be is bipolar disorder and opioid use disorder, two disorders at the same time, stand alone, so that if the substance abuse disorder went away, they would remain a bipolar individual. That disorder would remain on its own. So the two disorders need to stand alone to be considered a co-occurring disorder. Surveys show that between 27 and 50% of people with mental health conditions also have a substance abuse disorder, and I think that's generous, right, for percentages of who have what we're seeing. A lot of times people will say, well, how do you know with the co-occurring disorders which came first? Because so many times we see anxiety and depression, and the anxiety and depression is manifested from the drug use. So if it's a true disorder, if it's a true co-occurring disorder, they would have come on their own independently. But if it's not, and one came before the other, that's where people get confused as to understanding the process. The most common mental health disorders that do coexist with substance abuse are the following. So we have our mood disorders. That would certainly be a strong person in the bipolar family. Our psychotic disorders run strongly with substance abuse disorders. That's co-occurring. Schizophrenics, your paranoid schizophrenics in that class. And our personality disorder folks. That cluster of individual has what you've heard as borderline personality disorder, narcissistic disorder, antisocial personality disorder. Those are the third class that we see that run the gamut, mostly co-occurring with substance abuse. Another question we get asked a lot, or I do, is why do some people become addicted and others do not? There's not this great answer for that. There's a lot of studies that have been done on it. We've done studies on Native Americans, we've done studies on twins, separated at birth, and so through all of that process, what they've come up with was some guidelines as why some become addicted and some don't. The age of early onset is certainly an indicator. So the younger they start using, the higher risk they are to become addicted in life later. So that's the first one. The physiological component certainly means your DNA, your biology, who you came from, genetically. And so that's continues to be a consistent piece of the puzzle. And lastly, our high-risk environments. So all of the domestic violence we see, all the physical abuse, emotional abuse, when you're in those high-risk environments repeatedly, that's one of the third indicators of why some become addicted and some don't. So you can see this formula is not something that we can't imagine, but this is the best we could do to put it together so we can kind of understand why some go this way and some don't. When you have these three factors, that's one of the tracks.
I have a question. Have we seen a rise in psychological or mental issues with the prescription medication making it more legal to take pills?
Well, it is pretty controversial. I believe it's been one of the conversations that we've had because they can get an opiate prescription from a methadone clinic or from a doctor, and it can carry over. So I would say yes. In that vein, it would be more prevalent.
Because they seem to think it's okay because it's prescription.
Right.
I'm not a drug addict. I get a doctor to give me the medication.
Well, and if you look at traditional models, an abstinence-based model, or a substance use expert can speak on that, on an abstinence-based model, it's not the path in which we seek treatment. It's a harm reduction model when you take a substance that's prescribed and the goal is to wean off slowly. Just two schools of opinions or thoughts from professionals out there. It really is.
But that's where the doctor shopping started too.
Correct.
Because one doctor starts to wean you off of it,
Correct.
so you go to another doctor.
Correct. And for our purposes, our drug court purposes, in dependency court, we have not admitted clients who are in the methadone program. So we are an abstinence-based program thus far. We've kept it open for conversation down the road, but right now, the treatment they seek is abstinence-based.
And I was just going to add that, certainly we see parents that prescription abuse isn't the issue. And so, the case plans that are developed that have to be narrowly tailored to those needs, we do pill counts. I mean, I don't personally go out and do the pill counts, but, pill counts, counting their pills to make sure that they're not using more than what they are prescribed. I mean, sometimes it's hard to monitor that. And, sometimes even medication is as needed. Well, what does that mean? Does that mean that they can take 5 a day? So, those are key things to try to monitor to ensure compliance and that they're not actually continuing to abuse it. But you're right, you're absolutely right that, a lot of times parents will go from one doctor to the next. I'm not sure that there's a good answer at this point as to how to prevent that from happening. So pill counts, that's all, medication management is specifically what we include in case plans and try to monitor it that way. Yes?
Is bipolar disorder strictly a genetic thing, or can it result from addiction as well?
Definitely, bipolar disorder is definitely an organically grown.
You're born with it.
Yes. Not safe. We have an RN also though.
The addiction is very, very complex. And what we tell the clients when they come in, when they sit before a psychiatrist, we have to call it something, but they'll say, well, it wasn't like that. And we say, we don't care. We're treating your symptoms. Their symptoms that we treat. But is there a genetic component to passing down mental illness? Yes.
Yes, sir?
You were talking about the pill count. What use is the pill count if you know about one doctor, but there's no doctor shopping, so the man went to see another doctor as well. They got 2 lots of the pills, and you already know about one of them. How are you going to know?
I don't know. The doctor network is tracked statewide, nationwide for distribution. I do know that. So there should be some checks and balances on the distribution from the pharmacy, unless they get them on the streets, which is two.
And as their disease progresses also, their behavior worsens. So you'll see a change in their behavior too, that maybe they're taking supposedly an opiate for some kind of pain, but they can't stop using though. Their behavior will get worse, and then everything shuts down as far as their ability to function. And they'll catch it on a drug screen if they're being drug screened.
I'm not sure how this is overall, but in Vero Beach, if you go and get a prescription, my doctor looks in the computer, can tell if you had just had a prescription filled in New York, like 2 weeks later. So it's in her computer. I don't know if that's across the board or.
Is that the part of the network that you're talking about, Ms. Johnson?
Right. So I think the second dose or the second bottle they're getting in that way would have to be an illegal, obtaining it illegally on the street, which is pretty much what they do if they're going to abuse a substance.
Oh, so all the state's doctors are leaving making
Yes.
those everywhere, okay?
Yes.
Any other questions for Ms. Johnson? We're going to allow you to ask questions at the end as well, but again, we have our substance abuse expert, Ms. Maxwell.
Coming up right after me.
Yes.
So my last little statement is that I remind people and I reiterate, a certificate of completion does not mean you're cured, because we do that, we give certificates of completion, and it's an indicator that you're certainly continuing in the right direction though, lifelong process recovery. Okay, have our next presenter.
I need to see better. I'm older than they.
Not by much. No, you're probably younger.
My name is Elizabeth Maxwell, and I'm a registered nurse and a licensed mental health counselor. And I've worked at Counseling and Recovery Center. I started working there as program director of the residential part, and now I'm clinical director. Before that, I worked in psychiatric hospitals and in pediatrics. I first started out as a pediatric nurse. I want to try to explain what it is we do at Counseling and Recovery Center and the different levels of care that we have, because I know sometimes it's confusing. And also, feel free, we're on 1025 Orange Avenue, the residential part. We've had people come through tours because they can't quite wrap around what exactly it is or what it looks like, and it takes some of the mystery out of it. Because when it comes time for reunification, sometimes, or for kids to visit, sometimes people that don't understand still think, well, you know, maybe it's not a good idea for the child to come there and, you know, and see their parent, because there's a lot of drug addicts around and things like that. So please feel free to come by sometime, and we'll take you on a tour of the residential part so that you'll, you know, it kind of takes the mystery out of it, of what it is or what it looks like and things like that. I'm going to talk about the referral process. I'm going to talk about all these briefly, but drug addiction is really complex. And let me just start. The referral process. Referrals can come from anywhere, from somebody's mother, somebody's father, a relative from New York, DCF, self-referrals, the legal system. We get letters from women in jail that are getting ready to come out and want substance abuse treatment. They come from everywhere, literally everywhere. Somebody's neighbor. Our priority population, and this is what will get you in quicker than anybody else who's waiting to come in. Our priority population is pregnant, injecting drug users, pregnant drug users, and people who inject drugs. And again, they get in quickly into one of our services. If they need residential treatment and there's not a bed, we'll get them into a day treatment service just to get them in and get them start going and trying to start pulling away from their drug use. And then the last part says all others. So we take anybody else who wants to come in, and again, we're a women's facility. Whether they have DCF or not involved in the legal system. Some people have nothing. They're not involved in anything, but recognize that they need to stop using drugs and they want help to stop. CRC, we accept pregnant clients with or without prenatal care and at any time during their pregnancy, anytime. We don't have an OB in our back pocket. I wish we did, but we don't. Many of them won't see them if they're too far into their pregnancy, so we use the emergency room. And the doctors have been very kind and generous and say, come back, and that's how they get seen towards the end of their pregnancy. The ones that sometimes they come in and they don't know they're pregnant. We do pregnancy tests on everybody that comes in. But it's easier to find an OB. And then we have to take them to specialists also because they're all high-risk pregnancies. So we get the initial phone call, and then we have an intervention specialist that will go out to see the clients. The clients either come to our office or the staff goes to jails, detox, psychiatric hospitals, medical hospitals, DCF hospitals, or to the client's home. Anywhere, whatever their barrier is, we go to where they are to try to, get them whatever kind of treatment they need or to be assessed. And we serve Okeechobee, Martin, Indian River, and St. Lucie counties, which means we'll go to Okeechobee jail, we'll go anywhere to assess a client, to determine their, what their need is. We're managed by Southeast Florida Behavioral Health Network, who also manages Palm Beach County. This works well for us because if we have a bed available, and we might have 15 people on the list and no one chooses to come at that moment, we can either send a client down there or they can send a client up to us. But the goal is to get treatment for women right away when they want it. Once a level of care has been established, and again, it doesn't matter where you are on a wait list, because again, we can have 15 people on it, and we'll call the first one and say the bed's here and they won't take it. We'll call the next one, they won't take it. We'll call the next one, they don't answer the phone. Next one, can you wait a week? Next one, there's multiple excuses why, all of a sudden it's time to come in that they don't want to access services. We don't throw that list away or have those people go away. We still try to reach out to them, but we're going to take and fill the bed with whoever is willing to come. So even though somebody comes, we always say, come in and get us assessed and we'll get you in as soon as we can. The levels of care have to do with the intensity, and I'm going to start explaining the least intensive to the most intensive. The levels of care are outpatient. This is a 1.5-hour group that meets up to 12 weeks. The clients are typically experiencing light drug use, or they've had treatment in the past and have relapsed and just needs to come back for additional support. This client is still able to function on the outside, and they have not decompensated enough to require more intensive treatment. Okay, that's the least. Now we're going to go into day treatment. Day treatment services meet from 9 to 1 p.m. Monday through Friday for approximately 6 months. When we first opened, we realized that a barrier to treatment was that all these people were in Okeechobee, Martin County, and once you're off and running in your drug addiction, you don't have transportation. So at 5:45 every morning, we have the white vans that go to all these counties and start picking everybody up so that they can be in treatment by 9 o'clock in the morning. And we do that Monday through Friday. Day treatment, again, is for clients who have mild to moderate drug use, and this, they require structured therapy to promote treatment progress and recovery and motivational interventions. If the client's condition continues to deteriorate at this level of care, and drug use continues, they're referred to residential treatment. Yes, ma'am?
Do they get drug tested?
Oh, yes.
Oh, okay. Is it like random, or is it every day when they come in, everyone sees them?
Day treatment is random, residential is 3 days a week, because we found that once everybody started using heroin, they would try to bring some in or pick something up at a AA/NA meeting and use it right after we drug tested them. So now they tell us we know we can't use in residential treatment anymore. We always get our information from the experts, and they're more than willing to give it to us.
Wow, okay.
So we do it 3 days a week, Monday, Wednesday, and Friday, including holidays. Yeah, if one of us has to come in and do it, we do it. When the client demonstrates an inability to control her impulses or use drugs, and there's a likelihood of harm to self or others or their property, they're referred to residential treatment for 6 months. At this stage, a client is unable to cope for even limited periods of time outside of 24-hour care. As their drug use continued, they have literally pulled away from humanity. Their addictive logic has taken hold, and their thinking is delusional, and they are paranoid. When they come in, it's typical, all residential treatment clients. My caseworker hates me. I need a new attorney. The judge doesn't like me. And by the time they get to, my family and this and that, they don't understand. And by the time they get to that, before they even start signing in, I'll stop and I'll say, well, let me ask you something. Do you have a drug addiction? Are you addicted to drugs? Well, yeah, that's beside the point. So there is no logic to their thinking. There isn't. The further away from their drug use, the more their heads clear, which is why it's important they're in residential treatment, because at that point they can't take care of themselves or somebody else. And you can't convince them that they were a bad mother. They always say, I was a good mother. I fed my kids. Yes, sir.
Is this all voluntary, or sometimes is it mandatory?
We get clients in that are sometimes court ordered to treatment, but they are free to walk out. And I want to say, I think the judge said too, that it's always good when they have something hanging over them. It's better for us too, if they have a DCF case plan, or they're court ordered to treatment, or if they have charges pending, because we'll take them any way we can get them. But it's more motivating for them to be in treatment and to stay. Because we have people that'll come in and leave an hour or two later.
I feel I should know this, but I don't think I do. How is this financed? Are the clients paying for the
We see indigent clients, and it's federal.
Is there a program like this in Brevard County? Do we have one like this?
I'm sure.
Maybe?
Is there a program in Brevard County is the question.
Like this one?
We have a provider, and it's just a much smaller scale, and smaller availability of beds than what I believe is your program. And it's our provider that's on our team as well, community treatment team. Community treatment center is our provider. It's just, and it's federally funded, and they do take indigent clients in Cocoa.
Yeah, we don't have the extensive treatment components that Ms. Maxwell is talking about, where they literally go around the county and pick people up to bring them for their sessions. I mean, we have some resources, but certainly not enough. I mean, unfortunately something that around the state we don't have enough resources.
So, again, in residential treatment, we, you know, accept pregnant women, and then their babies come, you know, are born. Sometimes they come back from the hospital, sometimes they don't. It depends on what they have after they're born, and where they need to go for treatment. I could tell you some nightmare stories, but I'm not going to. But I'll give you one example. We had a young woman who was getting prenatal care and going to specialist but she needed to deliver her baby down in Miami so that the baby could immediately have cardiac surgery after it was born. So, but we kept her in there safe until that happened. But yeah, sometimes it's not good. You know, what happens afterwards to babies and things like that, and where they end up. And we end up taking them to a lot of specialists too. We're in Orlando, take them everywhere for whatever follow-up procedures, follow-up for different things that local pediatricians are concerned about. So we take them outside of here as well. The program in residential treatment is really structured because by the time they get to this point, they're really not functioning at all. So they're, to give you an example, you have to have a little bit of a sense of humor to work with these people too. But they're up at 6:30, they have to make breakfast, everybody has chores to do, they don't have like people cleaning. They're the ones that have to, and they do a terrible job, so we're always after them about. And then we're always arguing with how you're going to take care of a baby if you can't take care of yourself. And, just a lot of things like that, a lot. But that's what they need is a structured program because they're trying to get their brain thinking again because it hasn't been. And even an hour and a half visit with their child sometimes is exhausting for them. They're exhausted.
Is there a typical age of these women that are going and sticking around, not leaving? I know several of my cases, the moms have been court-ordered, and they go and they don't last not 5 days. 10 days would be like probably the longest before she just up and walked out. She had it. And
well, reunification from seeing it from substance abuse and we all work together, the caseworkers and everything, but sometimes they say, come here, can we reunify them? And we're like, no, this one can't cook yet. Gets real frustrated. So we try to kind of hold off if they're still in treatment to give them feedback that it needs to really happen slowly.
But like the women that go here, is there like a particular age or is it all over? I'm sure they must be quite young, but are there also older women that?
Right now we have an 18-year-old that just aged out of foster care. She's still a kid. And we have somebody in their 40s that have children also, but adolescents who are already starting to use. I've been there 16 years and now, what I'm hearing, hi, remember me? I used to visit my mom here. Yeah. So we have to keep trying. We just have to keep trying. Sometimes it sounds impossible, but we have seen miracles happen too. We have some people with no support, and they come back a couple of years later and they go, I'm working, I've had my kids, most aren't educated, so they do have an uphill battle. So after they leave residential, you just can't house people for that long a time and then say, get out. It doesn't work. So you can't do it just because they need to gradually get back out. So we put them back into day treatment from 9 to 1 for about 8 weeks until they get used to being in the community again. And by then they're used to going to AA, NA meetings, and they have a support system. And then after that, they go into what's called aftercare. Aftercare is where a counselor goes to their house and will meet with them and provide support. And that can happen up to a year. Nobody ever needs it for that long, but it's there. We had a woman that had 7 kids and she was in her 20s. She needed all of it. She needed to come to residential twice. She needed day treatment. She needed aftercare twice. And who wouldn't with all that, with all the pressure. Transitional housing, we have 6 beds for clients who need a safe place to go while they attend day treatment. Sometimes they're homeless or don't have a safe place to go, so they're there and they attend day treatment. Or for residential treatment clients who don't have a place to live after they leave and they gradually gain employment, save money, and then move out. But it's really hard for some of the ones that are on probation to have to pay that off and everything when you're making minimum wage. It's really hard. So they can stay up in there for a year, sometimes a little longer. Nobody ever does, past a year, but they can. And sometimes their families start talking to them again because they've stopped. So then they have the opportunity to go back. Maybe their mothers or fathers will give them another chance. And all treatment services, the clients have treatment plans just like DCF and things like that. And we do HIV, we have we link up with community services to make sure they get HIV testing and education, testing for hepatitis C, because everybody has it now with the heroin use, TB testing for venereal disease. Like I told you before, pregnancy testing, all the residential clients get pregnancy testing. And yes, lots of them don't think they are, but they are. Most of them feel I can't be. And prevention, prenatal specialist. Sometimes they have to go to West Palm to see specialists. Specialists for newborns, psychiatric evaluation. We have a psychiatrist and a nurse practitioner that come for that, and they're and also while they're in treatment, they get domestic violence, anger management, chemical dependency education, parenting, healthy start, family sessions, meditation, how to have healthy relationships because they don't, and they wouldn't know one if they saw one. Communication skills, stress management, journaling, nutrition, health groups, relapse prevention, discharge planning, crisis planning, individual and group. And they learn how to socialize and communicate appropriately. Again, and in residential, we take them to AA and NA meetings daily. The evidence-based programs that I listed up there are programs that we use throughout the different services. Clients come in, we pre and post-test them to make sure that they are learning what they need to learn in order to stay, to keep from using again. Relapse and recidivism, I just want to say that this is, I know it's getting late, it's a quote from the National Institute of Drug Addiction. Many people equate addiction with simply using drugs and therefore expect that addiction should be cured quickly, and if it is not, treatment is a failure. In reality, because addiction is a chronic disorder, the ultimate goal of long-term abstinence often requires sustained and repeated treatment episodes. So when they come back, we welcome them back. We don't judge them. We say, come back. They may not need residential the second time if they've gone through it. They may need day treatment or something else. But we welcome them back and say we'd rather see you here than read about you. Yes, ma'am.
I'm gardening for 2 young boys, and the mom is incarcerated for drug abuse and vulnerable child. And she was on probation, but she didn't follow what her rules were, and now she's back into jail. How many times does the law let that, because there's got to be a decision made for the child, I mean, to be for adoption, or, is there any limit if they just don't make an effort and they just keep going back? Is there any number that,
Since Ms. Maxwell is the substance abuse expert, I'll talk to you about Chapter 39 and permanency. There is no law per se that says, okay, you get 3 chances to become substance free, but 12 months to permanency is what is mandated by Florida statutes. Now, we all recognize and know if you've been a guardian ad litem volunteer for any length of time that doesn't always happen. You don't always get to permanency in 12 months. Sometimes we're calling case numbers from 2013. So there really is no magical number. It's really just a matter of trying to provide as much services and oversight through the treatment facilities to try to help the parents overcome their substance abuse problems. And if you can't get to that point, then we have to look at other options for the children, because really you all are here because of the children. That's your role. And so for example, we had a client in adult drug court. She graduated, and then the dependency case, she was reunified. And then a few months later, unfortunately, we were there for a shelter hearing. She relapsed. And so we're going through that case now again for the child, but we have to consider how long do we wait for the child. So there's really no good answer, but hopefully that answers at least to give you some guidelines. Yeah.
And the last thing I just want to say is the clients, they're all coming in using heroin. It's heroin, the drug that's, and the Roxy's or Dilaudid. They even tell me it's cheaper in Broward County. Heroin, 1 hit of heroin will cost you $20 in this area. Roxycodone, $30. And a Dilaudid will cost you anywhere from $35 to $40. But they all say if you go down south, it's cheaper. But they moved into heroin because it was cheaper than the pills once the pills became unavailable to them. But they're a mess when they come in. I mean, physically too. You can see the changes in a week or two of just nutrition. They don't look like the same people.
Probably a really stupid question.
No.
I probably should know this as a guardian ad litem, but how exactly does a person take heroin, and are there multiple different ways that they can take it, or like is it a shot or a pill or a snort, or I don't know.
They'll inject it.
Okay.
They inject it.
So there would be signs you would see, unless they inject it. Can you inject it anywhere?
They get a
Or is it-
physical when they come in, and they've used up all their veins already. When we go take them for a pregnancy test, it's hard to find a place to stick.
And it's their arms. Like, can they put it in their butt? Let's say?
Arms, neck,
Anywhere you have a
anywhere
vein.
you can get a blood
Anywhere
vein.
you have a vein.
Why do they put it in their arms? It's so obvious. They should put it
Well, they
somewhere
have
else.
other people shoot them up too, so it's not like.
How much, like, in this county or throughout Florida, FLACA, and I know that that's been bad things, is that still on the increase? FLACA?
Sometimes the girls, when they come in, they'll say, I got arrested, but I think they put FLACA in it. That's why I got arrested. Because you would kind of know because of the bizarre behavior. It's not something you can sneak and not visibly see. Where you might do heroin, you could be in a corner someplace, passed out.
And the second question is there any research out on
We do have a lot of people that come in because the nurse and me, we do they do a physical and I go in with the doctor all the time, but we do have cutters that come in, self-mutilation. But if they're using heroin, they're not so much, right.
Guys, we're gonna have to go ahead and wrap this session up, and we're gonna take about a 15-minute break.
So can I just close by saying thank you so much to our treatment team and our experts.